Hello students, my name is Dr. Daivik Shetty and I am your orthopedics and PMR subject matter expert at Manipal Medes. So after a lot of delays, finally the NEET PG 2024 exams have concluded and we have a lot of recall questions from set 1 and set 2. So let's quickly dive into what are the important insights from the exam, mainly from the orthopedic point of view, and then let's go on to solve all these recall questions that I've compiled. So few insights regarding the paper, specifically what changes have come from previous year to the present year. The first thing that is very evident is that questions are more longer and more clinical based, and also there are a lot of image based questions, that is ortho radio integration questions are increased. And also there are less number of PYQs and direct one liners have reduced. So this is a trend that you can expect in the coming exams as well, because slowly our exam pattern is evolving towards a USMLE based exam, and that is why questions are going to be more clinical, longer questions. There is going to be integration of radiological and anatomical aspect of it in orthopedics, and slowly the amount of PYQs and direct one liners are going to reduce. The questions are going to be more comprehension based. And also a very important takeaway from orthopedics mainly in this exam is that learning orthopedics from an imaging aspect, mainly radio anatomy and anatomical integration of orthopedics, is also equally important. Not just remembering one-liners and fracture eponyms, you also have to understand the imaging aspect of it. And because of this reason, in the Manipal Medes video modules, I've included the radiological anatomy and also the bony anatomy of every disease. So in every lecture video, you will see that there is a bony anatomy area where I've shown you in sawbone models, and also I've included radiological labeling of each disease. So that is why it's important. And also in this exam, we can notice that more and more topics are being covered. In the previous year examinations, it was these same high yield topics from which questions were repeatedly asked. But in this exam, few other questions have been asked from areas that are normally not tapped into, like areas of basic sciences, area of spine, from where questions are normally not asked, but in this exam they have asked a few questions. So remember to study more topics in orthopedics. Now let's come into the recall questions that I've compiled from set 1 and set 2. Before I go into these questions, please understand that these are questions that are purely recreated based on recall of a large group of students. I've made sure that I've taken the poll or the understanding of a lot of students, a survey of a bigger group of students, so that I can give you a more accurate recall. So the question can be as similar to the question that was asked in your exam, and also the options are also the same as that in the exam. And that is the reason I've taken 2 days to get back with these recall videos. But please understand, this is as real as it was given in the exam. So let's go into set 1. So we'll go set wise. So set 1 was the morning exam. The first question was this, that there was an implant given, an X-ray image where an implant was put in the proximal femur region, and they've asked you to identify which implant it is. The options were condylar plate, locking plate, dynamic hip screw, and LCDCP. So 4 options. Let's look at this X-ray. In this X-ray, can you see how there is a screw here? This is a Richard screw, and along with that there is a plate, and this is put in the proximal femur, and we've discussed this in 2 sessions, mainly in the video module and also in the INI-CT recall session. We've discussed about a specific type of implant which has a screw and a plate, and this is responsible for compression at the fracture site, and that is why it is called as a dynamic implant. It is called as a dynamic hip screw. So this is a snippet from one of those videos where I've taught to you about dynamic hip screw. So the answer here is pretty simple. It is a dynamic hip screw, mainly used in proximal femur fractures. The rest of the options, all of them were plates. So here you can see this is not just a plate, it has a screw along with it. So it cannot be these 3 options. The answer is dynamic hip screw. So this was the first question from set 1. The second question is more of a forensic and ortho based question, where they've told you that there was a sexual assault suspect patient whose age was 18 years, but he claims to be 16 years. Which is the best X-rays that will help you confirm the diagnosis? The options were elbow and hip, knee and wrist, knee and elbow and wrist. Again, we've discussed about the fact that wrist, hand and knee X-rays, these are the best to determine age. These are the best to determine age. So here hand is not given. Hand is usually the first one that we do, but hand is not given. The rest are given. Wrist and knee is given. So B, option B, wrist and knee becomes the answer here. So the second question answer is knee and wrist, best x-rays to confirm age. Now coming to the third question, this was a spine question where they'd given you an x-ray of a patient. This was mainly the lateral view x-ray of the spine. Looks like a lumbar or a thoracic spine. Here the history of road traffic accident. Patient is brought to the casualty. X-ray is done. X-ray looks somewhat like this. What do you think is the diagnosis? Your options were compression fracture, chance fracture, burst fracture, and fracture spinous process of the vertebrae. So this concept is again discussed in our video lectures where I've told you that you can divide the spine into three columns: anterior, middle, and posterior column. If only anterior column gets involved, then the fracture becomes a compression fracture. If both anterior and middle column is getting involved, then they become a burst fracture, can be stable or unstable burst. If all three columns are getting involved, if it is a flexion distraction injury, then you have a chance fracture where the fracture line passes through all three columns. Can be bony or can be ligamentous, but passes through all three columns. And ironically, in my video lecture also, I've used the same image that is given in your exam. The same image was given here and they had asked you what is the fracture pattern. And we know from our video lectures that if the fracture passes through all three columns, we call it either a chance fracture, or we call it a seat belt fracture because seat belt injuries are more common here, or we call it as a jackknife fracture because the body goes into that jackknife position, goes into flexion and distraction. So this is a chance fracture where all three column is getting involved. Again, the image is explained in the video lecture. Ironically, it is the same image that I've explained with that was given in the exam. Now coming to the fourth question, another image-based question where they've told you there is an 18-year-old patient has a history of fever, raised ESR, X-ray is done. So from what I've collected the common consensus, they've told me that it was a diaphyseal area where the tumor was present and there was a sun ray type of periosteal reaction. There was a sun ray type of periosteal reaction, and we know that history of fever and raised ESR was given in the option. Now students had a few confusion in answering this question. Their first confusion was that because it is a sun ray appearance, should the answer be osteosarcoma? The second doubt was that because there is history of fever and raised ESR, should the answer be osteomyelitis? Let me clear these two doubts to you. The first thing is, whenever you're diagnosing a tumor, the location where the tumor is present becomes very important. So we know that the location of the tumor is diaphyseal. So we know osteosarcoma is not a diaphyseal tumor, it is a metaphyseal tumor. So osteosarcoma cannot be the answer, even though there is a sun ray periosteal reaction. Remember in my video lectures I've told you that periosteal reaction is not pathognomic or is a definitive diagnosis or clinching factor for any tumor. Sun ray appearance can be seen in osteosarcoma, but it is not a rule. Sun ray can also be there in other malignant tumors like Ewing sarcoma as well. Periosteal reaction only occurs because your tumor is growing rapidly. Okay, because osteosarcoma is a very rapidly growing tumor, you have this speculated sun ray appearance. But sometimes, even if you have an Ewing's tumor that is growing rapidly, you can have a sun ray appearance. So, sun ray appearance cannot help you make a diagnosis. The next factor is history of fever and raised ESR. If you remember my video lectures, this slide was there in my video lectures where I told you that in Ewing sarcoma, there will be features that resemble acute osteomyelitis. Patient might have an increased ESR, an increased CRP, patient may have anemia, patient may have intermittent fever. So even in this history of fever, raised ESR is not osteomyelitis. The answer here is Ewing sarcoma because it is a diaphyseal tumor, rapidly growing tumor, and also features of fever and ESR is seen in patients with Ewing sarcoma. So the answer here is Ewing sarcoma. Okay. Now coming to the fifth question, here again an X-ray is given. This is a lateral view of an elbow and they've asked you the classification and grade of the X-ray shown below. So if you look at this X-ray, you can notice that there is a break in the continuity. Can you see there is a break in the continuity here? And this is at the supracondylar humerus region. So you have a supracondylar humerus fracture and if you see it is completely displaced. It is a completely displaced type. Now let's go back into what we've discussed about supracondylar humerus fracture. We've discussed about the classification system being a Gartland classification. And in Gartland classification, if there is a completely displaced type of supracondylar humerus fracture, then it is grade 3. It is a grade 3. So this here is a grade 3 fracture. The other options were Salter-Harris classification. Salter-Harris classification is done for epiphyseal injuries. They're done mainly to look for epiphyseal injury. So in this image here, it's a lateral view. You can't see the epiphysis and the fracture appears to be above the epiphysis. So this cannot be a Salter-Harris classification. This is more in favor of a Gartland type 3 fracture. So that is a very simple question. Another question that was asked is what type of amputation is shown in the image, and the image, from what I've recalled from a lot of students telling me, that there was a section, a gross section like this of a leg which was amputated, and they could see a tibia and a fibula remnant in that, and also a long posterior flap was seen. Now, if you see something like that, what is the type of amputation that you suspect? Let's look at the options. Below knee amputation, above knee amputation, Chopard's amputation, and Lisfrank's amputation are your options. Now let's go back to our lecture videos. What have we discussed here? We've discussed about this image where I've told you about different levels of amputation involving above knee and below knee amputation, and also we've discussed about foot amputations where Chopard's amputation is when there is disarticulation at the mid-tarsal joint, and Lisfrank's amputation is when there is a disarticulation at the tarso-metatarsal joint. Now coming back to our image, in the image we can see a remnant of tibia and a fibula. So it cannot be a foot amputation, it cannot be a above knee amputation, it has to be a below knee amputation. So a very simple answer, below knee amputation, because you see both those leg bones. Now coming to the 7th question, another question where a clinical scenario is given and a radiological image is given. So they've told you that the patient had a following fracture that is shown in the x-ray here. What is the duration of immobilization in short leg cast for such fractures? Again, not a direct question. They have not asked you what the fracture is. They have asked you how long will you immobilize such fractures in a short leg cast. So let's try to diagnose this x-ray. If you look at the x-ray here, you can see that there is a break in the continuity in the 5th metatarsal base, and that is called as a Jones fracture. We've studied about this. It is a Jones fracture. Now let's go back to what we've studied in Jones fracture. So this was my slide on Jones fracture. I've told you that it is a fracture of the base of the 5th metatarsal at the junction of metaphysis and diaphysis. And I've also told you that in Jones fracture, because there is a tendon that is pulling the fragment, you need to immobilize such fractures for a slightly longer period. Normally 4 to 6 weeks is when we immobilize a fracture, but in Jones fracture the immobilization has to be slightly longer, that is 6 to 8 weeks of immobilization with the short leg cast. So the answer again is a direct answer here. It is 6 to 8 weeks. Okay, in Jones fracture 6 to 8 weeks of immobilization is done. Now coming to the 8th question, a child has recurrent tooth abscess, he has a deformity of the lower limb, the image is given above, and also lab values are given. They've told you that the serum calcium is normal, serum phosphorus is normal. Some people have told me it was reduced, but doesn't matter, any of those is fine. They're told parathyroid hormone levels are normal and ALP is increased. What is the diagnosis? And your options are nutritional rickets, vitamin D dependent rickets type 1, vitamin D dependent rickets type 2, and hypophosphatemic rickets. So these were your 4 options. Now let's go back to how to approach this question. We've covered this in the video. I've talked about this table of different lab values seen in different types of rickets. And in this, if you can notice, parathyroid hormone is normal only in vitamin D resistant rickets, and vitamin D resistant rickets is also called as hypophosphatemic rickets. We've discussed about the pathophysiology of the whole vitamin D resistant rickets. So based on these tables, we can quickly answer this question as hypophosphatemic rickets because parathyroid hormone levels are normal. So this is how you're going to clinch this diagnosis. Coming to the next question, complaints of pain radiating to the back of the thigh and the leg. After lifting weights, MRI was done. Based on this sagittal cut of the MRI that you're seeing, which nerve root do you think is more likely to be involved? And they've given you a sagittal cut of an MRI. So the examiner now is expecting you to read not just X-rays, MRIs as well. So based on this cut, you have to tell where the disc is come out. So you have to mark the vertebrae. So this here is the sacrum. This is L5. This is L4. this is L3, L2 and so on. Now you can see a disc that has come out like this. So there is an extruded disc here, and this is between L4 and L5. Now between L4 L5, which nerve root is commonly involved? To go back to that concept, we've studied about this, that there is an exiting nerve root, there is a traversing nerve root, and when there is a disc at L4 L5 level, usually it is this traversing root that is getting affected. More commonly, because it is a paracentral type of disc that comes out, you will have a traversing root that is getting affected. So if you have an L4 L5 disc, it is this L5 traversing route that is getting affected, and that is why the answer is L5 here. Okay, that is about question 9. And question 10 is slightly controversial because few students have told me that this question was asked in the exam. Few of them were not able to recall this question being asked, but anyways, let's discuss this for completion's sake. They've given you a tumor and they've asked you to diagnose what type of tumor it is. It was a distal radius X-ray that was given, and students have told me that the periosteal reaction was a sun ray appearance. Here we don't have much to go by. We know that this is a malignant tumor. This has a sun ray appearance. So we'll have to look at the periosteal reaction. Although I've told you that periosteal reaction are not pathognomic of tumors, but here we don't have a lot of information. We only know that because it is an aggressively growing tumor, and also that there is a sun ray appearance, and based on the options and the periosteal reaction, we've discussed about periosteal reactions and also about osteosarcoma in detail. So this has to be osteosarcoma. Based on whatever little we have to go by, this has to be an case of osteosarcoma. So these were the 10 questions that were asked from set 1. Now let's go to set 2. In set 2, there were again 10 questions asked from orthopedics. The first question, they've given you that there is a female child who had fallen at home, and after that he had gotten an above elbow cast. Later on, the child developed the following deformity. What is the most likely fracture that would have initially occurred? Now look at this image that has been given here. You can see that this is a case of cubitus varus. It is not valgus, it is cubitus varus. And we know that the most common complication of supracondylar humerus fracture is something called as a gun stock deformity or a cubitus varus deformity. So this deformity matches with the image that is given. So most likely the fracture is a supracondylar humerus fracture. In lateral condylar humerus fracture, you will get cubitus valgus, not cubitus varus. Okay, so this was a straightforward question. Coming to another question, this is from injuries around the knee, mainly sports injuries. A football player had a twisting injury to the knee. Clinically, no bony injury was noted. What test is this examiner performing? And they've given an image like this where the examiner has flexed the knee to up to 20 to 30 degrees and he's looking for instability. Now, two things come to your mind. You either think of drawer test or you think of Latchman's test. Now, how do you differentiate between both of them? Look at these images from my video lectures again. In drawer test, the requisite is that your knee has to be at 90 degrees of flexion. But in Latchman's test, the knee flexion has to be somewhere around 20 to 30 degree. So if you look at this again, look at the image again, it's at 20 to 30 degrees of flexion that the examiner is looking for instability. So the answer here has to be Latchman's test, not drawer test. Don't get confused. The knee flexion is giving you the answer. It is the Latchman's test, mainly done for ACL instability. Okay, so this is how you will arrive at the diagnosis. Now coming to the third question, damage of which structure will affect the linear growth of the bone? Few students have told me longitudinal growth was asked, few have told me linear growth was asked, but both of them are the same. Now if you go back to basic science lectures, I've told you that in the epiphyseal growth plate, mainly in the germinal zone of the epiphyseal growth plate, it is an important zone because it results in longitudinal growth. If this is damaged, your longitudinal growth is also affected. So based on this much information, you can tell that the epiphyseal growth plate is important for linear growth. Okay, very simple one. They've not asked you about layers, they've just asked you which structure is getting involved. So it is epiphyseal plate. Now coming to the fourth question from set 2, patient is not able to perform the OK sign. Which of the muscle is affected? And your options are flexor pollicis longus, abductor pollicis brevis, lumbricals and opponens pollicis. Now OK sign, where do we do the OK sign? Let's go back to our lecture session. We've discussed about a compressive neuropathy mainly in the median nerve called as a Kilo-Nevin syndrome, where anterior interosseous nerve is getting affected, and when anterior interosseous nerve is getting affected, patient will not be able to do this OK sign. because his flexor pollicis longus and flexor digitorum superficialis is getting affected. So instead of doing like this, he will keep it like this. So in patients who are not able to perform OK sign, flexor pollicis longus is the structure getting affected. Okay, so that is the answer of this question. Coming to the fifth question, another 10-year-old child presents with knee pain after road traffic accident. Physical and radiological evaluation reveals injury to the marked structure. Identify the structure, and they've given you a radiological image like this. They've marked a certain structure and they've asked you which structure is getting affected. Your options are anterior intercondylar area, Gerdy's tubercle, medial tibial condyle, and tibial tuberosity. So the area that is marked here, can you see here? The area that is marked here is the prominence in the tibia, and we've talked extensively about tibia and the anatomy around the knee, where I've shown you these images and I've tried to explain to you how the patellar tendon comes and sits on an eminence called as tibial tuberosity. And in children, they usually have this trauma followed which they'll have tenderness at the tibial tuberosity, which is called as Osgood-Schlatters disease. So here they've not asked you about the disease, they've asked you about that structure, and that structure is tibial tuberosity. This structure that is marked is a tibial tuberosity, and the condition, if they had to ask, was Osgood-Schlatters disease that was being mentioned in this question. Okay, coming to the sixth question, this is a controversial question again. They've told you that there is a fracture that is operated on. They've put a plate in the femur bone. Now they're asking you what type of healing is happening here, whether it is primary healing, secondary healing, creeping substitution, or intermembranous ossification. We've discussed this in fracture healing. When I've talked about fracture healing, I've told you about primary and secondary bone healing. In primary bone healing, it is mainly healing without any callus formation, mainly by direct osteoanal remodeling, and this is slightly inferior, and this is seen when there is compression plating that is done. Compression plating. Compression plating is, examples I'll tell you, are whenever in the forearm you put a plate in the radius or ulna, they are compression plates. In them, you see primary healing. But here, what plate they are seeing here in this image is not a compression plate, it is a bridge plate. And IM nails and bridge plates, IM nailing, that is intramedullary nail, and bridge plate, like the one that is shown in that X-ray, these two, healing occurs with secondary healing. Okay, healing occurs with secondary healing. So the answer here is secondary healing, not primary healing. I've seen a lot of recalls in which they've talked about primary healing being the answer. But if this was the X-ray that was given, where a femur bone is given and this plate is applied, which is a bridge plate. In femur, you apply a bridge plate, and bridge plating, secondary healing is the answer, not primary healing. Okay, so this is something that needs clarification. Coming to seventh question, again a straightforward question. What type of translocation is seen in diaphyseal tumor with small blue round cells? Whenever diaphyseal tumor with small blue round cells is given, you always think of Ewing sarcoma, or you can think of peanut tumors. Can be any type of peanut tumors or Ewing sarcoma, and we know that in Ewing sarcoma the translocation that you see is T1122. So the answer here is T1122. Okay, then coming to the eighth question, again an image based question. They've given you this X-ray. They've asked you what is the condition shown in this X-ray. So here you can see that there is a forward slipping of one vertebrae over the other. This is L5, this is S1. So there is a forward bending or a forward distraction of L5 over S1. And we've discussed about a condition where there is forward slipping of the vertebrae, and we've called that as spondylolisthesis. Do you remember this? We've discussed about spondylolisthesis. So this condition here where there is slipping of one vertebrae over the other, the answer is again spondylolisthesis. It's not renal osteodystrophy, metastasis, or Paget's disease. Okay, so that was the eighth question. The ninth question was a question asked from basic sciences. For a long time, there hasn't been any question asked from basic sciences, but now they've asked one. So what is the question here? They've told you that the patient is osteoporotic, and based on the lab values, which values will you think is increased other than ALP and N-telopeptide? So we know that in osteoporosis, osteoclastic activity is more, because of which the bone quality reduces and the bone becomes porous. Now, what is the bone turnover marker? Mainly ALP is one bone turnover marker. Then if osteoclastic activity is increased, when bones are getting broken down, what are the other markers? Can you remember those markers? We've discussed about N and C-telopeptide. They've mentioned that in the question itself, C-telopeptide. Other bone breakdown markers are hydroxylysine, hydroxyproline, and another one called as tartarate resistant acid phosphatase, also called as TRAP. So going back to the options here, only one bone breakdown marker is given in the option, and that is TRAP, TRAP. Okay, so the answer is TRAP. Then coming to the last question, this is an anatomy question that was asked. You are examining a patient whose foot is in inversion and you applied some resistance holding it in inversion, and then you're trying to palpate a tendon behind the medial malleus. So it cannot be anterior tendons, they have to be in from other compartments. So anterior tibialis cannot be the answer. EHL cannot be the answer. The fourth option, again, I've marked it, written it as EHL here by mistake, but it was again another anterior compartment muscle. So three anterior compartment muscles were given, and then other option was posterior tibialis. So these three are not the answer. So the answer becomes posterior tibialis. So here the answer is tibialis posterior. Okay. So these were all the questions that were asked from set 1 and set 2. I agree that the exam was slightly more difficult than previous years, but more applications required in such exams. So I hope you've done well in this exam, and if not, if you're giving another attempt, hopefully you will revise in a more clinical fashion, you will study more images, and if you want any help with such an approach to studying orthopedics, you always have Manipal Medays through which you can do your NEET PG preparation. Happy learning.